Welcome everyone to today's webinar. I'm Anuja Vaidya with Beckles Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in today's webinar, we will have one poll question for the audience. The question will pop up automatically on your screen. You can then select your answer from the options and click Submit. Thank you in advance for your participation. Today's session is being recorded and will be available after the event. In about a week following the webinar, we will be sending all registrants a copy of the presentation to the email you used to register. Please be patient as the post-webinar preparation of materials can take some time. Today's presenters will be Mary Beth Mitchell, Chief Nursing Informatics Officer at Texas Health Resources, Jody Padden, Nursing Informatics Specialist at Texas Health Resources, and Rhonda Collins, Chief Nursing Officer at Vocera Communications. At this time, I'm pleased to turn the floor over to Mary Beth to begin today's presentation.
Good afternoon, everyone. We're very happy to be here and to share some of our thoughts around cognitive burden and how we can use technology to help with that. And first, before we get started, just a little bit about Texas Health Resources. You can see on your screen there, we're a multi-hospital IDN. For the purposes of this slide, we have 29 hospitals. As with many of you, it changes occasionally. And 17 of those hospitals are really on our same instance of most of our technology, our EHR, as well as some of our integration and other technologies. The other hospitals are joint ventures, and we don't have that same relationship with them in terms of our technology. We also have about 900 physician groups and advanced practice providers that are part of our Texas Health Physician Group. But the thing I like to share the most is that we have 75 nurses and 5,500 physicians, and this is a lot of our clinical base that we'll be referencing today. And so that's a lot of clinicians that are using our technology across our hospitals. You can see how many visits we have. The other thing we're really proud of is some of our awards, especially I'm really proud of our magnet status. We have 5 magnet hospitals, and the rest of our 17 are pathways to excellence. We're HIMSS MRAM stage 7. We won the Davies Award in 2013, and every year we're pretty much one of the best companies to work for. So like I said, we're really excited to share our conversation with you today, and I'm going to turn it back over to Rhonda for some opening comments now.
Thank you, Mary Beth. This is going to be an open conversation. You're going to be listening in on a conversation with the experts. We're really thrilled to have Mary Beth and Joni with us. Just to set the conversation, you know, overall, all of us in this room together believe fundamentally that technology should enable clinical needs and enable the clinician to practice within the scope of their care to the highest level possible of their education and enable them to do the job that they need to do. And it's not done outside the experience of the patient and the patient's family. So, and looking at that, many of you are very familiar with Maslow's hierarchy of needs. You know, basically all of us need to feel like we're functioning safely and with basic needs like food and water. So when you talk about the basics of technology, it has to fit into the context of their workflow. It has to be something that is utilized seamlessly throughout what they do. It's easily adopted, or it's easy for them to use to enhance that caring experience or the cared for experience. The other thing, of course, is to be able to feel like they're connected, or they have the tools they need to ensure the safety of themselves and their patients. And then if we look at how clinicians need to be a part of the organization in understanding quality outcomes, how that they can have a sense of accomplishment and having a voice in these technology decisions that are made for them and have the power to make decisions that affect practice. We're talking to clinicians who are members of magnet hospitals, and that is the very foundation of magnet hospitals, that nurses have the ability to be involved in the decision making that includes what their experience is and the patient and family experience. And then ultimately, any hospital adopting technology wants to have a culture of high reliability and a climate of respect, control, and support. And we find that when nurses have reached that state of self-fulfillment and the self-actualization, that results in a very dynamic, free-flowing conversation about what makes the adoption of technology better. So I really want to go on to the next slide. I want to ask a question of all of you on the phone, and let's just tee up this conversation. How much do you think technology is adding to the clinical cognitive load at your hospital? Please feel free to select one of the following: high, medium, low, or not at all. Is cognitive burden or cognitive load something you even think about? Use your screen to select one of the choices of high, medium, low, or not at all. Anuja, are you getting some answers?
I am seeing some results right now, yes. So the poll results are that 56% of respondents said that it is high, 39% said it is medium, 3% said it is low, and 1% said not at all.
Okay, so you confirmed that we are discussing a timely topic, and I think that it's really important that we really bring this to the forefront and we all are able to move with the information. Thank you. So let's start with discussion point number 1. Mary Beth and Joni, I want this to be a live, dynamic conversation between our two experts. You show us what you want us to see on the screen, but tell us what you see as the impact of cognitive burden on nursing workflows today.
Great. This is Mary Beth. Joni and I got interested in looking at documentation burden probably a little over a year ago. And as we started looking at documentation burden, we quickly realized that it was not just documentation. It was not just the EHR. It was really the entire, it was the environment. And I think this slide, it talks about communication, but really when you look at the workflows, what we used to have back when I was a staff nurse, you just had one-way communication between two parties, and that communication was very linear. Today, everything is interactive, everything is integrated, we have many more stakeholders, and we are communicating on different levels and using different technologies all at the same time. So,
and our clinicians really trust the different pieces that they're using, sometimes to a fault, where they will think that communication is complete and is going through the way that they need it to, when in fact they really should have picked up the phone, or they really should have put something in the EHR. That making sure that they're putting the right information in the right spot sometimes is very difficult for them, especially with all of the information that they're faced with and the different ways that they need to communicate.
And I will say we have been on our EHR since 2006. So we have a long history, and the technology in our hospitals has become pretty ubiquitous, and it's not necessarily, I like to say it's not the thing, it's driving the thing, which is patient care. And our staff really they just use the technology, and sometimes in good ways and sometimes not.
One of the things I liked about your question, Rhonda, on the how do you really know what's going on, and when we've overloaded the mule, so to speak.
Right.
I was actually born here in Texas, so you'll excuse me.
I'm fine with it.
You'll excuse me if I use a colorful expression or two. But you know, when you've overloaded the mule, when the mule begins to kick and throw some of the burden off. And
that's right.
Oftentimes we will see with our staff is that when we begin to show a non-adherence to a workflow, then that's when they're not following the path, then the path has become too hard. Or there's something in the path that we need to go in and adjust for them to make that much easier. It's just, we see events, we will see requests for change, we will see non-compliance, we will have things from leadership that tell us that there's something going on and we need to examine the cognitive burden around it. And it used to be, you need to fix the documentation so they can click a better place or fewer clicks or one of those things. And that's part of it, but that's not really all of it. It's how they think about it. It's the more important piece.
So how do you really find out how they think about it? Do you have formal methods whereby you can gain that information, or is it through observation of non-compliance?
We have all of that.
Okay.
So we have our clinical work groups, our user groups from all of our hospitals. We have between 8 and 10 of them. We have like an adult nursing work group. We have one around women's services. We even have one around trauma, behavioral health. We brought in dialysis when we needed to work with them. And they really keep us updated on what the issues are. You know, our organization has lots of committees and lots of groups, and, you know, things kind of swirl around. And so we hear about this in a lot of different ways. But we also can see this through audits and the record. One of the things that really came up recently through our reliable care blueprinting, which is where we are really pushing for standardization, and we're using our technology to help force some of that standardization to decrease variation in practice. What we've seen is some real kind of passive aggressive behaviors and just out and out not doing something, or if something's required, putting something inane in the comment field to let us know that they don't like what they're having to do. So, you know, with all of our good intents, we inadvertently add to the burden. But I think this slide really speaks to some of the things that we see that adds to the burden, especially errors. We're starting to really look into the errors from the IT informatics side, not just on the clinical side, but what is the impact of our technology on why we're having these errors. Joni's got a couple of examples of things that we're trying to do to deal with some of this that aren't necessarily technology related.
Yeah, they're not necessarily technology, but one of the things that, so we like to look at things that work and look at the literature and evidence base. And the example that's on the slide is one that I'm sure most people are very aware of, is that there have been several studies that have shown that when a nurse is doing a med pass, if they have something visual on them, a vest, you know, a different color, something that shows that they are on a mission, they are doing something that they need to focus on, leave them alone. That they need to stay in that workflow so that they can, you know, do the entire med pass and do it safely. Well, we try to take that same example and then apply that to things that they're doing within the record, so that when they are in a workflow in the record, something that needs to be done, that we're not interrupting them throughout the record, that they have the ability to do the entire piece within 1 or 2 screens, that the information that they need is all on one screen so they can find it, that they don't have to go out places to look. And not only is that easy, because that's just the nice thing to do, is to make it easy.
Right.
It reduces the cognitive burden of the task, is that I don't have to remember to go to this screen and do that, and that screen to do this, and here to look up some more information. That if we can keep it there and improve the visualization, one of the things I really like about every improvement that we make, it's improving how they see it. It's improving the visualization of it. And that seems to be some of the pieces that really make it a lot easier. The other instance I would give for this would be a timeout. So when you're in the world and you're doing a timeout, you have to stop, everybody focus on the timeout, and then walk it through. And I'll give you a personal example for when I was at one of our facilities that worked beautifully. I am allergic to chlorhexidine and latex, and I went in to have a procedure done. And the nurse who was caring for me made note of my allergies, asked me about them, and then said, stop. Went and got the anesthesiologist, the surgeon, and the other nurse who would be circulating. They all came into the room, discussed with me what my allergies were, how that went about, and then made sure that then they went to their room, made sure everything that I was allergic to was out of it, and then did the timeout. When I went into the room, they did it again to make sure that they had done all of the steps. But she really paid attention and focused on that and was able to do a safe timeout. So we do that within the record so that we really give it to them to be able to do that quickly, efficiently, and together.
And I think we'll talk about that more with one of the other questions, but really trying to drive the workflow and the record to a single function, as opposed to 10 years ago, build it 3 different ways and let them choose which way they wanted to do it. That really just increased the cognitive burden. And, you know, I think everybody knows now that to create something one way, train on one way is really kind of how we want to go.
So do you find documentation, you know, while you standardize documentation, but to standardize other workflows, like how you do your communication, or how you do your transfers, or how you manage your notifications, all of those things are part of the cognitive burden.
And I think if we go to the next slide, we'll start getting into some of that.
Okay.
One of the things we really saw around communication is, and Joni mentioned this earlier, is this over-reliance on technology. So we all thought technology was going to save us from everything bad that could happen, and we see that, you know, ignoring alerts, not making calls correctly. One of the interesting things that happened recently is with our Vocera devices, we now have our call schedules built in to our Vocera system, and we recently had a downtime, and it was a network downtime. Everything went down, and they had no ability to even know who was on call. And so this over-reliance on technology, I think trying to find the balance of that. You know, also not having a standard communication strategy. That's one of the things we're continuously working on, is how to standardize our communication. We still see great variances across our hospitals. Some hospitals have best practices, others are really still struggling. But we haven't gotten down to a single device either. We have a lot of different devices, and I have mixed feelings about that. I don't think we should just limit to one device to do everything. We have different tools. You know, I have an Apple Watch, an iPhone, an iPad Mini, and an Apple tablet. I mean, and a MacBook, all at the same time, and I'm using them all. So I think giving people options, but having standardized workflows is really important too. But a lot of things are exposed in downtime.
Yes. And one thing that I would say, you mentioned the culture of communication is, you said you're not standardized across the system. That's because almost everywhere I go, and I work with thousands and thousands of folks on discussing these topics, is that you can have different cultures from unit to unit. Your ICU has a culture of communication, whether they use SOAP or any other standardized methodology or none at all. And so we do rely on too much on technology rather than the discipline guiding the technology. You know, we allow the reverse.
It was interesting during a downtime that, and we now have it in our downtime packets, is that they are so comfortable with using the electronic health record or using their Vocera device or using some of those things. But if you're in a real downtime, and there's a lot of stress that goes on with that. So your main focus is on your patient, correct?
Right.
Well, all of the different tools that you're used to using may or may not be available to you, and that's very stressful.
Right.
So at the very top of the instructions is, remember, the phone still works. And that way, so I haven't heard from pharmacy. Well, did you call down to the pharmacy?
Yeah.
I can call? Yes, you can still call down to the pharmacy if you need to. Just that gentle reminder that it's okay sometimes to fall back on stuff that you're not used to using any longer. That still works.
When we first put in the secure messaging, the Vocera Communication Suite for secure messaging, I was at one of our hospitals that was using it real well between clinicians and physicians, and they had created these templates where they could send questions to the physicians. And so I was talking to the physicians about how they liked it. And their biggest complaint was that when they send the nurse back, they keep saying, okay, thanks, or sending a happy face. And I was like, that's what you've got to complain about? Is that, you know? So I think when we get to that point, is that they really are using these communication tools, and they're really adopting them into their workflow, and I think we're seeing, some good results with that kind of thing.
So let's talk a little bit about information overload and what happens as that adds to the cognitive burden, that worrisome thing at the back of your mind. I've got to deal with this. Don't forget.
I'll let you go first.
Yeah, I think
I can talk for too long.
Yeah, this slide really, we've addressed a lot of that we have information scattered throughout, people having multiple ways to enter information. I think the other thing that we're really starting to address, and I don't know why this has been hard for our users to understand, is they don't review information at the same place where they put it in. And they continuously start going to where they documented to look at the information rather than pulling up the reports and the various tools that we've created for them to review information. And we also have multiple sources of truth. When you're highly integrated, where is the source of truth? Is it within everything within the EHR? Is it within the source systems? Can we count on those being the same? And how do we address those? And then things that are discrepancies within the record. Do the notes support what's documented on the flow sheets, or do we see discrepancies in a single provider's or clinician's documentation? And then we still have a lot of silos in our workflows. And I'll let Joni kind of finish up this as we move on to the next question.
So the mantra of don't review it where you document it. Going through Joint Commission and in prepping for Joint Commission, which you're always in constant prep for a survey, those kinds of things. And I like that because it gives us the opportunity to go out and talk to clinicians, not about their Joint Commission survey, but how the tools that I'm going to show you that are going to help you pass survey are also the ones that will help you take care of your patient. So let's get out of the flow sheet for a minute and let's go look at this report, shall we? And walking them through the thought process of, if you take them back to the flow sheet, you're going to have to dig for days. If you will go to this report, look, it pulls all of these things together for you. And wouldn't that be helpful in your normal day to be able to see this complete picture of your patient? And it's one of the things that breaks my heart when we do this is they go, how long has that been in there? That's great. And you look at your watch and go, 8 years? But who's counting? So the ability to help them find those reports, the things that really pull all of it together so that they get a better picture, are a joy when you get to actually teach the end users. And then I love best of all when I get emails back or when I go out to an entity and they say, when you showed us that opened up this whole new world, that saved me 30 minutes in my day of not having to do it. And then I know that I've picked the right thing to do for a living.
That's amazing. Yes. So that takes us to how can we continue as informatics nurse leaders using technology and all these supportive tools to enhance the clinical workflow, enhance their efficiencies.
Yeah, go to the next slide there. I think there's several things. I think we should be moving to more predictive and prescriptive tools so that the clinician is presented with information about the clinical status of their patient and they don't have to go look for it. That we need things that are context specific. So when we barcode the patient, it opens the chart. When we barcode the med, it documents it. Those are some pretty easy context specific tools. But even within our communication tools, when I'm in a patient's record and I need to notify the physician and I'm using my communication tool, it should know that I'm on this patient's record and let the physician know I'm asking about this patient. So I don't have to text out, the patient's name and all of the information. So putting things within context. And then making sure that we have a good visual synthesization. Is that and I think that's a little bit what Joni was talking about. I think integration. We recently integrated our vital sign machines in our low acuity areas, the Dynamaps, and immediately within a couple of hours, just not being able to, take that vital sign, read it off of the screen and having to go into the record and document it. Now we can scan the patient, enter the vital, hit start on the vital sign machine. It takes the vital signs and they're automatically in the record. except for respiratory rate, and they still have to count those, and it's still 16.
Everybody breathes at 16, right?
But that's
amazing.
You know, that's next week's problem to solve. And then I think also having better presentation tools. We're starting to do some things around visualization. And then I added this, I think having electronic unit boards and whiteboards. We are just now starting a pilot where the data from our EHR feeds the patient room board. And I don't know how that's going to go. I think it will be a big win because they don't have to go in and write their name on the board at the beginning of the shift and the physician's name. All of that's going to come in. It will pull in their pain goal. But then they also individualize those boards, and they've lost that ability. So we'll see how that goes. But I think anything we can do to cut down on some of that peripheral work, you know, having to put all the new admissions on the whiteboard on the wall, and having that stuff come directly in.
And I'm an old ACLS nurse, so an old ICU nurse, so I think in algorithms. And one of the pieces I really like about the predictive and prescriptive analytic ability within the record is that a lot of what we do, if you see this sign and symptom, you really need to be looking at this way in which to deal with it. And the record's ability to help you recognize those things and then suggest the top 5 actions that you should be taking, not to limit you to those, but to remind you, give you an easy path to do the correct thing for whatever this may be, reduces that cognitive burden. It allows them to see, okay, here's what's being recommended. It doesn't mean I have to do it. We always give you the ability to practice at the top of what you need to do, but really and truly for about 80% of what we do, we can give you the top 5 things in which you need to pick to be doing for the patient. Let's make that easy. Let's make that something that's on the screen for them when it comes up, that anytime you get any kind of a notification or an alert, it should be actionable, and it should be actionable in the background so that it's telling you the things that you need to do and allows you to do it. That you can go seamlessly from one to the other, and then we will have done a better job.
That's right. That's so true. Because it's just as important to suppress what you don't need to know as it is important to put through what you do need to know. And as you said, it has to be actionable. Very important. Mary Beth.
One of the things, kind of back on that previous slide, that we haven't done a lot of that we are looking at is actually reducing some of our documentation and taking out things that aren't required. But that is not going to be a huge impact. What we discovered, pretty much everything we have in there is required. And so we're really trying to look at other ways. And I think communication really can play a piece of that. Making sure we have a clear strategy around our communication. The hospitals that are using our communication tools well, they have escalation pathways. I love the CEO. She's moved on. She's not our CEO now, but she always talked about, a PCT goes into a patient's room. The patient said they need a pillow. She gets sidetracked when she goes out to get the pillow. It doesn't come back. That message escalates to the next level of care and on and on. And the president said, one day I'm going to get a request to go deliver a pillow to somebody's room. And I'm not going to think that people aren't doing their job. I'm just going to think that everybody's busy. And, the communication worked till where it got to her. And I think having those escalation pathways is really good. Making sure we manage our communication around roles as well as persons, that our technology is flexible, that we can integrate various technologies. One of the things that we're doing, and this is kind of, this is a pet peeve of mine, is having to document assignments in multiple systems. Everything from the bed to, the EHR to Vocera to our teletracking, we're having to make multiple assignments. And one of the things we're working on with Vocera is to be able to better manage those assignments so that they're made in one place and those assignments then go out to all of the different stakeholders. And I think that's, really incumbent on the role of informatics to kind of identify those and then work with our vendor partners to pull those pieces together. We've been able to bring the different vendors together to start working on this assignment piece. And also, alarm management's not on this slide, but I'm going to go ahead and address it now. It's probably on the next slide. But really being able, go back one, being able to send alarms to our communication devices. And when we talk about Vocera, we have both badges and we have phones where we use communication. But we're just starting to really identify which alarms we want to go to the different communication devices. But with alarms, the other thing that we did that isn't necessarily part of sending an alarm is we did a review of our alarms with all of our physiologic monitors and our telemetries, and ran it through an algorithm that we had created and discovered opportunities to change the alarm settings within our devices. And we had to work through our quality committees and get MEC approval. But I'll give you one quick example. We found that we had an alarm setting for SaO2, pulse oximetry, of 90%. So it alarmed anytime it was 90% or below. But our policy said we didn't treat a low O2 sat until it was 88%. So we were able at one hospital to reduce that one alarm. We reduced 55,000 alarms just for that 2 percentage points of O2 sat. Yeah. And that was like nothing, right? And so really optimizing our alarm settings, training our nurses to pay attention to their individual patient needs and not just necessarily take the alarm settings. And then the final piece is to send those alarm notifications to the appropriate person when there are alarms.
That's a tremendous reduction of a cognitive load to take 55,000 at one institution out.
And it's not just, it's great to escalate those alarms, but you have to step back and say, what do I need to do to reduce the number of alarms?
That's what I really enjoyed when we were discussing this earlier, and you said it already once, is that it's often just as important what you filter out as what you let through. And this kind of an example that we've been able to show just really supports that.
Exactly. That's really tremendous. I know folks are doing this all over the country, but you're the first person I've heard to give me an actual number of how it has reduced the cognitive noise. And I think there's a lot to be said. We're not talking about it in this particular webcast, but cognitive load adds to burnout, stress, all of those things that make it when you go home, you're still hearing monitors in your sleep. You go to sleep with it, you wake up with it. And all of those things, if we can reduce and make it better, our providers can do a better job.
And we've really pretty well, we've embraced secure text messaging. And a lot of our physicians have really embraced that, especially our hospitalists. I think one of the barriers we still have is we do not have the secure text messaging on a mobile device for our nurses yet. So they still get those messages on their badge, but then they have to go to a desktop to send a message. And I don't think they seem to like what they have, but I don't think they know that it could be better if we could put it on a mobile device. So that's where I'm really hoping that we can go in the near future, is to get those secure messages on a mobile device for our nurses.
And I think as our millennials have to come into the hospital more, that the ability now for patients to text and to communicate with their physicians and their providers by texting, because we actually tried this, we tested this out, but it was not very well received, and the patients really enjoyed more of that voice communication, use the call, speak to someone. But I think as that demographic begins to really swap, that we're going to see a lot more of the patient texting and the patients wanting to use those kinds of pieces as communication instead of so much voice within that realm. But I think it's going to take a couple of years before that really begins to hit.
And one other thing that I think will really help with the cognitive and documentation burden of our nurses is for patients to enter their own data into the record. And, they can do that through the portal. We have questionnaires. And we're starting to look at ways that the patient's data that they enter for their medical history, their surgical history, can then become part of the record. And
I can tell you that I'm a big user of my patient record within my EHR. And anytime I go to the doctor's office or enter the hospital, they all comment on it and say, "You're a great user of your EHR. This is great. We have all of this information." So I know that it makes a difference. It's made a difference for me. Next slide. So our third and final question before we take some questions from the audience is, how can informatics nurses and clinical leaders evolve information in ways to decrease this documentation burden while increasing effective communication? You don't want to become so digital where you're typing everything that you no longer talk to each other, but yet how do we balance the load for the caregivers?
So like I already mentioned, having more patient-entered data. And one of the things that is a concern to me is we have got to get our communication tools more intuitive. And what I mean by that is we are trying to have patients use tablets. We have interactive TVs on our beds. We have communication tools between, as Joni mentioned, between patients and staff. We have interactive videos for patient education. And right now it's falling on the nurse, if not somebody else, to educate our patients on how to use those tools. And also our nurses, when new things happen in our EHR, we send out tip sheets and web-based training somewhere else. We need all of that information about how to use the features of our technology, whether it's for the patients or the clinicians. We need that within that tool that they're using to be intuitive. Maybe we put Alexa in every room, but
I was going to bring that up.
We really need more intuitive ways so that our staff are not having to add to their cognitive burden by teaching patients how to use the technology we're giving them. Even our TVs now are, can be very complex for some of our patients.
And add the fact that we've just given them medications in which to make them a little fuzzy, and it gets even harder.
It does. And I think just changing the channel with a pillow speaker can sometimes be
a little more challenging than you wanted to be.
And we talked, about integration earlier, but integration comes with its own set of complexities too. If the data doesn't go, the IV pumps can be difficult to manage integration. It adds to it's a great safety, but it's not easy. And we need more voice assistive devices. We need the ability to scan supplies and have them document, all of those kind of things.
So if I ask you to put on your, look in your magic globe here for the future, do you anticipate seeing a day where devices like Alexa are in all patient rooms so patient can say, "Alexa, put the temperature to 68.
Yeah.
Alexa,
we should probably call it Florence if it's going to be in the patient room. Florence, I need I need to trademark that quickly.
I think
write that down.
The head of Twitter at HIMSS, was it last year or 2 years ago, talked about, in the smart room of the future, having that controlled by an assistive device that you speak commands to. So yeah, absolutely.
Yeah. So frequently we look at something like this that it helps the patient to feel more connected in assistive devices, but what we're talking about, it would be interesting to see and anticipate what kind of load that would give to the nurse in responding. How much of that would be required to go to the nurse and how much would just happen within the technology.
And that's what we need. We need more of this, to just be part of the technology and not require intervention to get it started, to initiate, to manage.
Exactly.
I would hope that Florence Alexa would also be listening to the clinicians when they walk in the room. So as the nurse walks in the room and notices that the linen is down or that the IV is running low, that spoken word as the ICU nurse of Florence, I need more IV fluid, and they would know where I am and what patient's room I'm in and those pieces, but then would have some form of check back. So Nurse Patton, I hear that you need more normal saline for Miss Robin in room 362. Yes, that's what I need, and then can carry through. I would always hope that when we get to that point, having a thick accent that Alexa seldom understands me, that Alexa would check back before ordering hypertonic saline on my patient for me.
Right.
Because that would not be fun.
Right, because those are definitely some of the challenges that we face.
So I think we've talked about a lot of the standardized tools for communication, but one thing I do want to kind of bring up is personal devices versus shared devices. It's still expensive to provide these tools, and we no longer have the luxury of being able to just buy a bunch of devices, whether it's a Vocera badge, whether it's a smartphone that we use for a mobile device. It's getting harder and harder. And our physicians have always been able to load all these tools on their personal devices. And I'm hoping that at some point in time, we'll be able to use personal devices for nurses for some of these functions. And I'm starting to explore where the opportunities are with using personal devices. I think we're a couple of years away, but it takes 2 or 3 years to get anything adopted. So that's an area I'd like to explore a little bit more, because I think we would have better adoption where nurses have the opportunity, if they choose, to have some of these tools on their personal devices, and being able to manage those in a secure way within the context of what those devices are used for and when they're used while they're at work, those kinds of things.
Do you anticipate that as you move toward, what we call BYOD, or bring your own device program, that it would add to the cognitive load if they're still getting work information when they leave work? Because I still get work email on my phone.
No, they wouldn't.
They would not.
They would not. And with our firewalls and our setups now, we already have the technology to control that. And so I think a lot of that will be driven by policy and how we treat our workforce. But I think we're all comfortable with our own device.
Exactly.
And we know how our device works. I was looking at an Android device the other day, and I'm trying to operate it like an iOS device. And so when we give nurses these tools, they may not be the ones they're used to, and they're not, it's just not their device. So I think this will really help with cognitive burden when they have the tools that they are comfortable with, that make sense to them, they know how to use them, and also to get rid of multiple devices. This has been our goal for years, is to have one device, and especially around communication. We need the same device that we make a call on, that we send a secure message on, that we receive notifications on around alerts. That all needs to be on one device. That we scan, that we barcode, that we track, all of that.
Right. That's a lot.
Well, I look forward, because and I know in the past that different vendors have had the ability to swap, so that on the same device you would be able to do personal. You went to one screen, and if you went to the next screen, then that was going to be your work device, and the two environments were truly separate. Right. And I think that as we go forward, that will reemerge and be something that comes up that will help with that cognitive burden as well, so that, and I'll use the example for this, is that on your personal screen, it's your favorite color, it has the picture of the kitten in the background, but on your personal screen, it is the approved colors and professional screen. It really looks a different way. So that there's a visual cue in there, as well as a way to swap between your two worlds.
Great. That's wonderful. Okay, well, we're coming close to the end. I just want to ask each of you, and I'll start with you, Joni. Is there anything else you would like our listeners to understand about cognitive burden in the clinical environment, and what you're focused on in moving clinicians to a place of an easier load? When they go home, they really get to go home.
They get to go home.
They get to take the knapsack off and then come back the next day more refreshed.
the drive that we have at the moment, my personal mission at the moment, is everything that I am involved with, I look at through the lens of reducing the cognitive burden on whoever it is that I'm working with, that we find the best way to present it to them and the easiest way for them to interact with it. And when we began to look at doing this, and it was this huge, it wasn't an elephant, it was a herd of elephants we were trying to eat with it, and you're never going to succeed for that. So instead, it is a drive for any project that I'm on, that's one of the lenses that I look at it through, is to really find the way to make it easy, make it fun, make it so that it's clean, clear, and that they can use it easily, so that it's very intuitive for them. And I think that's really my takeaway for cognitive burden, is that, one, be aware that it's there, and two, figure out some way in whatever you're doing with it to reduce it. And then that will begin to accumulate over time.
Wonderful.
Hopefully.
Mary Beth, you have been one of our great leaders in nursing informatics for a long time, and we've heard from you a lot. I've learned a lot from you, and I just, anything that you want to add that you think that maybe we didn't touch on in this conversation?
Well, not that we didn't touch on, but I would really sum it up in about 3 or 4 things that I think are going to have the most impact on reducing cognitive load. One is we have to make our tools more predictive, and they have to present us with information. We've got too much data and too much information to have to go searching for it. And so we need better access to the information, and we need it presented to us. I think integration and interoperability is key, and I think the work that's going on around FHIR is really exciting, and I think we're going to see over time a lot more of that interoperability. Like I said, we're now having to make assignments in 6 different places. I believe in the next couple of years, we won't have that. So the integration and the data moving between our systems, nothing makes me, more upset than to have to take data from one system and manually enter it into another system. That doesn't make sense. And then the other thing is more mobility. We need mobile devices that can manage multiple applications, so that we don't have to have different devices for everything. And then the final thing is, it has to be intuitive. We can't keep all these training materials around that people never look at.
That's right. And I think that's another WebEx, the mobile nurse, what that really means. So just to wrap up our conversation before we start taking questions, that I think what I've heard from you is that you need to focus on developing a climate of high reliability. So your process, your policies, your protocols match the action, where you have standardized protocols and folks can follow those, and with the standardized acts, it drives compliance, and then it also can drive outcomes. And strive for a culture that fulfills the nurses' needs at every level, the tools they work with,
right.
The engagements they have with their coworkers and with their patients and with their families. That technology is the enabler, it's not the owner of the experience. And you structure clinical workflows in partnerships with IT, because workflow drives everything.
Exactly.
workflow. It drives everything. So at this point, we want to be sure that we have time for some questions, and you're welcome to ask any one of us a question. And Anuja, I'm going to turn it back over to you to manage our question and answer period.
Fantastic. Thank you, Mary Beth, Joni, and Rhonda, for that excellent presentation. We will now begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled "Enter a question for staff" and clicking send. We'll kick off with this first question. What are the signs of cognitive overload we should look for?
There's not an easy answer to that. I think you see it in the chaos of a unit. I think you see it in alarms being missed. We had one of our recent Joint Commission visits, the staff were not acting on alarms quick enough, and this was brought up. And I think that's a symptom of cognitive overload, that there were alarms going off and that the staff were not acting on them. Where in another hospital where they're not as overloaded, that wasn't brought up. I think not following prescribed workflows, that we see a lot of workarounds. I think it's in their practice that we see that. I don't think there's a way to measure it.
The other way that we tend to see it, because we are well connected with our end users. We have so many groups, and we are well connected, so they feel confident in reaching out to us, is that when they have an area of cognitive burden, something that is really putting pressure on them or that they feel isn't working or they're struggling with, we will hear it through our clinical work groups and be able to work with them on why they're feeling that way, what the piece is behind it, how we might be able to go about it. And oftentimes, I often refer to the electronic health record as often the filter that catches the things that come through, because at the end of the day, everybody's struggling with it and they want to figure out how to document it, that we often serve as the switchboard. We will hear about a cognitive burden from alarms, which is something that we can deal with, but that's really something that administration needs to be helping with, and that we can then escalate appropriately and give them the right path in which to follow through. So I think in identifying cognitive burden, it's listen to your staff and what they're struggling with, and then you can begin to understand what their burden is and help them.
And also for us to review our errors. And, it surprisingly enough, it's been a challenge to get informatics and IT to look at some of those incidents reports in terms of what's the IT impact of that, what's the cognitive burden impact on that. And we're starting to see where some identification of cognitive load based on errors.
Great, thank you. Any other questions?
Great, thank you so much. Yes, we do. We have a few coming in from the audience. Right now, we have a two-parter question. Do you have strategies on assessing competency on use of EHR and electronic documentation? And how often is this done in your organization?
Yes, we do, and not as regularly as we'd like to. Not as well. So some of our hospitals do that very well. We have a really pretty good process for any onboarding or new hires that come in, that they're taught, and then they have set evaluation periods within their 30, 60, 90 days, and that includes competencies within their documentation components. We've also seen when we've rolled out certain workflows or things through our reliable care blueprinting, that we will do competency checks 3 months, 6 months afterwards, and the tracking of the outcomes for that is really where then the entities will begin to go back and look at the documentation competencies. Are they documenting heart failure correctly? Are they documenting dry weight correctly? Those kinds of pieces that then, if we're beginning to see a reduction in outcomes, that we can go back and then address not only the clinical skill, but the documentation of the clinical skill.
Great.
But it's not, I wouldn't say we have the answer to that.
No, we are always working on a better answer for that.
Thank you.
Fantastic. The next question we have here is also a two-parter.
Oops.
We lost you.
We lost you, Anuja.
And if so...
Could you repeat the question, Anuja? We didn't hear you.
Oh, I'm so sorry. Yes, absolutely. So the first part of the question is TextHealth Informatics monitoring marks for certain types of alarms that cause fatigue? And if so, what are the alarms that have been identified back for?
Yeah, I addressed this work a little bit in terms of looking at the alarm settings that we have, and it's part of a larger alarm management program that we're in the process of implementing, and one of our nursing informaticists is gathering all of the data. And so the first phase of this is really changing our settings for our alarms, and then the next phase will be to really look at how those alarms are being utilized. So we're getting ready to change, and we've done this in a couple of hospitals as our pilots. Other things like some of our arrhythmia alarms, like not having a high alarm for a couplet PVC, having that as a lower alarm, and changing how often alarms repeat and those kind of things. And so I think that's really a strategy that we're taking. I'm very excited about it, and it's totally being driven by nursing informatics and our quality departments at the hospitals. So we expect to see real good things. And then the other piece of that is the escalation of alarms and how we're sending those alarms to be responded to. And the other thing I also am interested in is centralizing some of those alarm notifications. You know, most of those alarms just go off at the bedside, and maybe having some centralized monitoring for certain types of alarms.
Just like in the record, if you get an alert, it should be actionable. If you get an alarm, it should be actionable.
Not just,
that's right.
Not just, oh, I need to.
Oh, that's nice. Yeah.
Oh, I'll file that away to add to my cognitive burden for later.
Yeah, it's not enough beeps for me to.
Yes, exactly.
6 beeps, not 4 beeps.
Next question.
Probably one more.
Anuja?
Check it out.
Let's hope they can hear us.
Yeah.
Keep our fingers crossed on that.
Is there anything else? Y'all there?
Well, it looks like we may have lost Anuja there, but I'll pop on here with another question that we have.
Okay.
Do you think that there is a limit to interoperability? For example, how many devices or alarms connected to Vocera? How do you measure that limit?
That's a really good question. I don't know. We have a lot of devices, but we haven't measured the devices. The thing we do look at, we have a lot of, you know, we have Vocera, we have now our vital sign machines, all of our IV pumps, all of our mobile devices. And so we are seeing overloading of our infrastructure, and we're seeing the impact of that on our infrastructure, and we're having to manage to that. The other thing where we see the number of devices and the number of pieces of data that are moving is when we have a downtime. We have had to set limits on how much data we will store up. And so we're only storing data for 4 hours. Anything over 4 hours gets dropped because it's backing up our systems and it's too long to queue it back. But I think that's a really good concept. We need to look at that.
Well, and I think that in getting the answer to that will be very sophisticated in that some areas will need more of that integration and others will not. And figuring out where the sweet spot is for any given area that needs those alarms.
That's right.
It does seem, and one other piece of this, I don't know if this is what person was thinking about, but we have to have a lot of extra devices because of charging and, you know, breakage and not working. And so we need better of that. We need, you know, longer battery lives, less breakage, more durable, easier to swap them out, those kinds of things.
Lighter.
Yeah.
All right. We are 1 minute from the top of the hour. Do you think we can take one more question in that 1 hour? In that 1 minute?
Sure, yes, absolutely. We can hop on to this last question we have here. How do you evaluate care units or clinician roles for excessive cognitive load?
I'm sorry, what?
How do you evaluate clinicians for excessive cognitive load? Just, I think what you guys were talking about is, you know, their workarounds, their...
Right. And, you know, we started monitoring how many hours they're working, right? And limiting the number of hours they can work in a pay period or how many days they can work. I think we need to start looking at, you know, maybe there's a limit on how many days they can be charge nurse or...
Well, and I think in looking to the evidence, there's actually an evidence-based test from NASA. Don't know if you've ever heard of them or not, that in researching this topic, because I like to read about this topic, NASA actually has a cognitive burden test that you can administer to anybody that they use routinely within the space program to monitor the cognitive burden on astronauts and how they're doing with this. And so I think that as this topic begins to grow, that kind of cognitive burden testing that people can self-administer will begin to grow. It was a very interesting read. It's available on Wikipedia.
Sounds like a great DMP or PhD project.
I've already got mine.
All right. Thank you so much, Beckers. I will turn it back over to you. Thank you, Mary Beth, and thank you, Joni. It's been a pleasure.
Thank you. This brings us to the end of today's program. Once again, I'd like to thank our excellent panelists, Mary Beth Mitchell, Jody Payton, and Rhonda Collins for your insights today, and to our audience for participating. Enjoy the rest of your day, and we look forward to having you join us for future webinars.
Thank you.
Thank you.